and the other side is a more curved, has a more curved shape, and this automatically enters into the deeper plane. So this instrument is useful for beginners in smile, because identification is a very critical step in the surgery. So last but not the least, this is another innovation from Dr. Sri Ganesh. He, in this particular technique that we call as lenticuloschisis, absolutely no dissection is required. So we are not using a dissector. Instead, we are using the microforceps to just peel the lenticule off the stromal surface very gently on both the sides, and once it is separated, it's extracted out of the pocket. So the conditions, the prerequisites for this particular technique is that the energy must be very much optimized, and you should not have any black spots or opaque bubble layer, and also the lenticule. Thank you for your attention.
Thank you, Dr. Sheetal, and excellent videos once again. Congratulations to Dr. Sri Ganesh and you for putting Bangalore on the international map for SMILE. I open the topic to discussions, and my first question is on corneal topography itself, that we understand the wide variety of topographers available, but do we all agree that the tomographic devices have a significant advantage over the OBSCAN or just the anterior elevation map based topographers?
In all the topographic images, what I feel that anterior is more important than the posterior. Whenever in the posterior elevations it is more, I hardly cares for it, I'll tell you honestly. I don't see much that later on. Because what I feel that even if you don't do any procedure, what will happen to the posterior flap, this map or posterior elevation is there, it remains like that only. And theoretically, you may say that yes, it may do some damage later on, but we have not seen anything. So I always consider if the anterior surface is okay, there is no much irregularity and asymmetry, I proceed for the procedure.
My viewpoint is that the two biggest advantages, I think it's a myth if we agree that all keratoconus starts on the posterior float. That definitely has been proven not to be true. But the advantage of the pentacam is you have a posterior float for reference to know what's going on. And there's a significant amount of study being done on the software to look at CTSP, PTI, because again, a keratoconus cornea is a normal cornea maybe 10 years ago. And the patient had zero refractive error, and then it developed an abrupt thinning in the cornea at some point. So there's a lot of study done in that, and that software makes it very easy for us to understand in which cornea it's an abrupt thinning followed by a progression to the periphery. And that's why I like the Berlin-Ambrosio display and the software with it.
Yeah, I also agree, because many patients have formed fristic keratoconus, which can be only diagnosed on topography. So there's no other way clinically. They don't have any scissoring, any clinical signs. So Berlin-Ambrosio display is quite useful. But I just had a question: is it really, like, we heavily depend on this bad display, but it has its own fallacies. So I think it's again important to correlate clinically before the final decision making. I had a question for Dr. Chetan. So in the Smart Pulse PRK, do you also use mitomycin? And what's the dosage and the duration?
In all cases, I use mitomycin, and the duration depends on two things. Mostly on the power, but also on the optic zone.
Yeah, because you are using this technology for high powers also, as you said.
Yeah, but for every case I'm using. Okay. Like even if I'm doing for 0.75, I'm using mitomycin. Okay. I'm not leaving mitomycin, because I believe that instead of ending up with scarring later on and being helpless, let me put mitomycin at least for 20 seconds now, so that I'm safer better on, like later on.
In all the trans-PRK cases, we should use the mitomycin without any consideration whether it is a 0.5 or 0.75 or -8, whatever there. Because I had a very bad experience. First, I was very confident why mitomycin C, and I never used it, and then we really felt in the trouble. After using the mitomycin trans-PRK, hardly I got any scarring at all. As far as the norms, that how many seconds you have to keep it. Higher the power, more you have to keep it. We sometimes keep to 60 to 65 seconds also if the power is more than 6. If it is less, maybe 20, 25. But usually 45 is the seconds we always keep it. That is the one thing which we kept it, and we do thorough wash and put a bandage contact lens.
Similar protocol we are also following.
So,
20 seconds minimum, can go up to 60 seconds depending on the power and the optic zone. If my optic zone is more, say 2 patients I am doing for -4, one has low 6.3 optic zone, another has 7.3, I will put mitomycin more time for the 7.31 rather than the 6.31.
So as Dr. Solanki also said, I think keep a standard protocol up to 4 diopters. I think 20 to 30 seconds is best, instead of trying to vary it in each and every case, because the OT staff also is not prepared for that. But if you're correcting a higher, like 5 to 6 diopters, then go up to 45 to 60 seconds. Avoid mitomycin C going into the fornices and other places, because that contributes to significant post-operative pain and sensitivity.
true. So that's what I told, that you have to have a thorough wash and don't apply too much. Whenever you're soaking your what do you call it? Sponge, you please keep it on the cornea itself. It should not move here and there, because these are small things which makes a difference. And the same way, when we used to have the alcohol-based procedure, the main problem was because the alcohol used to spill in the fornix and the patient was having the inflamed eye next day. So in the trans-PRK, we are very happy there is nothing is there in this one. And as far as the topography is concerned, I like to mention few things here, that don't see too much on the colors, because colors is one which can sometimes give you the false images. Always see on the numbers also. You correlate with the numbers and then you will see. We had one patient where everything looks green. And when we compared and when we see closely, then we said it is early keratoconus was there. Means there was the difference was there in the hourglass. But if you see only the colors, so after seeing the colors, we say, no, you are fit for that. Be careful. Try to correlate with that also. One question for Dr. Sheetal.
Yes, sir.
About the relax. This is in my mind from last many times, and I feel that whenever you are removing a plate and then that space remains like that only, it never heals, if I'm not wrong. Because collagen never heals, as we do in the LASIK also. Even after the 4, 5, 6 or 10 years, we have seen the flaps comes out. So have you come across anything where this space, which from where you removed it, you had a problem, or the DL case was there or not? Because we are having a lot of tissue manipulations, and with the instruments we are doing manipulations. So do you have any? Because I don't have any experience, but it is in the back of my mind. I'd like to ask you anything which is happening in your experience.
We did have a few interface issues out of the more than 7,000 eyes that we have operated. It's a very, very large data. I think 2 or 3 patients had successive patients, basically. They had DLK, picture resembling DLK. So we just washed them. It was something in the fluid, some toxic reaction. But normally we never see any such post-operative problems, inflammation. So we just put them on a steroid regimen of 4, 3, 2 and 1 prednisolone tapering every weekly, and they all do fine. And once we had, I think 2 patients did have infective keratitis. So that was also again inside the pocket. So usually if you have any such interface issues or even epithelial ingrowth, so in smile, there's no classical epithelial ingrowth that you see. It's more of a epithelial implantation. That's when you are doing the manipulations, when you are dissecting the lenticule, or you're coming too many times inside and outside of the pocket, you may implant some loose epithelial cells which are there around the incision, and sometimes they can proliferate. So if any interface related problem is seen, usually the treatment is very simple. You just give a wash in the